Good evening and welcome to tonight's webinar, the introduction to antenatal shared care in Rockhampton. My name is Jodie Sargent. I'm Education Coordinator for Central Queensland Wide Bay Sunshine Coast PHN or Primary Health Network, and I'd like to warmly welcome you. I'd also like to warmly welcome Dr Helen Wiltshire, who will be your presenter tonight. She is the General Practice Liaison Officer for the PHN, and she'll commence shortly. Before we get started, I'd just like to let you know that we've got a couple of handouts, and you'll see on the right-hand side of your screen that there's a 2020 Intro to Antenatal Shared Care and also the CQ Whole of Region Shared Care Summary. So those can be downloaded and accessed after the webinar. You'll also see on the right-hand side of your screen that there's a chat function, and you can submit questions throughout the evening, which I'll be monitoring, and we'll have an opportunity towards the end for a Q&A with Helen. Before we get started, I'd like to acknowledge the traditional custodians of the lands on which we meet today and pay my respects to elders past, present and emerging. And without further ado, I might turn off my webcam and hand you over to Helen Wiltshire. Thanks, Helen.
Thank you, Jodie. Thank you, everyone, for making the time to join the webinar tonight. I did see some of the list of attendees, so I know there's some people that I've met in person before, but some people that I haven't as well. So as Jodie said, I'm the GP Liaison Officer for Maternity Services for the CQ Wide Bay and Sunshine Coast PHN, but my work really focuses on the Central Queensland area of that. I will also kind of do my disclosure and potential conflict of interest, and that is that my clinical work is at True Relationships and Reproductive Health, working mainly in women's health, but also around sexual health. I do some teaching for GP registrars, medical students, and the FPAA certificate attachment candidates, and that I have done some presentations for Bayer and MSD around product education events and received sponsorship to attend meetings and conferences. So it is a recorded session tonight. Please do pop your questions through to Jodie and I'll do my best to answer those at the end. What I'll do now is turn off my camera and flick over to my screen so that we can run through the slides. So what we'll do is run through those learning objectives, the model of antenatal shared care here in CQ, some of the screening recommendations before and during pregnancy, our communication and clinical handover systems, some resources that are really useful, and looking at some of those best practice guidelines as well. I would like to acknowledge and thank Jodie for all the work on the back end of getting a webinar up and running. Also to thank the CQHHS midwives, Sharon, Judy and Catherine, for giving me some support and information, particularly around the Rocky Hospital local changes. Thanks to Dr Gary Rajapati, who's a GP at CQ Doctors with a special interest in women's health and particularly antenatal care, and I've used some of her previous information later on in the talk. And also particular thanks to Dr Wendy Burton, who's a GP in Brisbane and the clinical lead for shared antenatal care through the Mater Mothers Hospital in Brisbane South. And with her permission, I have used a lot of the resources from the Mater Mothers GP alignment for shared care. The other thing that we'll cover just at the end is some of the changes that have come about due to the COVID-19 pandemic. You may well be aware of these already, but there are just some small changes around routine antenatal care. I do want to highlight that this has traditionally been a one-day workshop, and I'm still hoping that in October we might be able to meet face-to-face for a shared care workshop. But what I've tried to do is take a one-day workshop and bring out some of the most important points and condense it down to an hour. So you will see that we're really only just touching on some topics, and it's a start and a bit of guidance with hopefully a chance to go on to more sessions later. There's heaps of information about pregnancy care, and these are some of the best recognised resources. So Australian Pregnancy Care Guidelines, Queensland Health Clinical Guidelines, and the Mara Mothers Shared Care Guidelines. We've also got our locally specific health pathways, and I'll show you some of those pages later on too. So just to see what you'll find if you visit these websites, this is the Australian Pregnancy Care Guidelines and the book that you can download on the side. Queensland Health Maternity Clinical Guidelines, and the front page of the Maternity Shared Care book from Mara Mothers. They have the longest established shared care alignment and accreditation program in Queensland. So rather than reinvent things, we use lots of things that they've already got established. Having a baby in Rocky, people have got the option of a variety of care options. So GP shared care is what we're talking about tonight. Through the hospital, there's also midwifery group practice. And if you're not familiar with that, that involves the woman seeing a known group of midwives, 2 or sometimes 3, who will care for her through all her antenatal visits. They'll be present and deliver her baby. They'll be with her in labour. And then midwives from that same group will see her up to 6 weeks postnatally as well. So there are lots of people who love that for the continuity of care. At Rockhampton Hospital, it is an all-risk model, so women who may have medical conditions or other pregnancy concerns can have that midwifery care as well. Other people might opt for complete hospital care, and that's with a combination of midwifery and medical input. And women who have what's considered a high-risk pregnancy would probably need to use that model as well. The maternity unit is featured on the hospital website. So if you want to look at the slides later and click on the link there, you can do a video tour of the maternity unit with midwife Judy. And that gives you a bit of an idea of what happens at Rocky Hospital. If there are people on the webinar who are referring into Gladstone, Billow or Emerald hospitals, if you have any particular questions, please pop them in the chat to Jodie and I can answer those. I have, I guess, focused on Rockhampton Hospital, thinking that that's where most of our attendees will be coming from this evening. To go back to basics, what is antenatal shared care? If you're not familiar with the concept, it's where the GP is the main maternity care provider. Generally, it's for those people who have a normal risk pregnancy, and it means that they have most of their antenatal visits with their GP. They book in at the hospital where they intend to give birth, and they generally would have 3, maybe 4 antenatal clinic appointments there. In the CQHHS, there isn't any formal certification or accreditation required to provide shared care for pregnant women. So you may have heard that in other places you need to attend a workshop or seminar or be accredited. In CQ, that's not the case at the moment, but the hospital do expect that people are a GP, that you're participating in QI and CPD activities, particularly in women's health, that you use the guidelines and protocols that have been established, and that you maintain good communication systems with the HHS. Shared care is a great option for lots of reasons. For women, it can really provide that continuity of care. So not only is she seeing a doctor through her pregnancy, but she can see then the same person to care for her baby and her growing family. It might be more appropriate for people to see their GP in a convenient location, close to home or close to work, or if they're in a more, a smaller area outside the major hospital location, they might find it more suitable to be able to work appointment times around family or work commitments. And they might find that with their GP, they can actually book their appointments out, several visits ahead, whereas the hospital may not give them that kind of flexibility. On the side of the GP, again, that continuity of care, getting to know a woman through a pregnancy and then being able to look after her and her baby afterwards is a great thing to be able to do. It really lets us use our skills that we've developed. People who are interested in women's health and maternity care obviously love to keep working in that area. And really, our community's future health is built on the health of mothers and babies. So this is a way of really making a difference in long-term health outcomes. One of the downsides of shared care is that you probably don't do it for the money. It's not something that it seems to be a huge income earner for GPs, although we will talk about billing and Medicare item numbers towards the end of the presentation. Pregnancy care can start even before pregnancy. And GPs own the field of preconception care. We are the health practitioners that people are seeing when they're thinking about a pregnancy, and can really make a difference early on. So the continuity of care can even start with contraception. Have you done any preconception consults? Have you thought about when they happen or what you cover? So it's kind of easy to start these conversations at the time of providing contraception or STI screening. It's a natural lead into the topic. And sometimes asking a simple question like, would you like to become pregnant in the next 12 months? Can give people an opening to think about their contraceptive needs, or in fact about planning for a healthy pregnancy. If you're looking after women who've got any kind of chronic disease or requiring ongoing medical management, then pregnancy planning should really be addressed as part of her care, so that any conditions are really well managed. Any adjustments to medication can be made before pregnancy. So what do you cover in a preconception visit? It's easy: medical and family history, medications, supplements, diet, exercise, smoking, alcohol, other drugs, screening tests, partner's history, gynae and obstetric history, have they been to the dentist, vaccinations, travel, employment, health insurance. So I'm being facetious, but these are all important factors in planning for a pregnancy. And what you might do is choose to plan a specific appointment to address some of these issues with patients. Or you might choose to use some of the resources that are available. And this is one that Wendy Burton has put together. It does look extensive, but it really covers a lot of the factors in terms of pregnancy planning. This handout's available through Wendy's website. You might be able to see that down at the bottom. It's called maternitymatters.com.au. There are other resources for pregnancy planning as well. So RANZCOG has got a good handout, and the Health Direct website, Pregnancy, Birth and Baby, has got some easily accessible information as well. I'd recommend that you try and have a quick look at websites before you recommend them, so you get a bit of a feel for how they're set out, the kind of information that they're offering, checking that they are offering up-to-date and Australian information. I do want to touch on genetic carrier screening, so preconception genetic testing. And this AJGP article has got a more complete discussion and outline around this, and I've just taken a couple of excerpts from it. Both RANZCOG and the RACGP are now talking about carrier screening. RANZCOG say that it should be offered to all women planning a pregnancy or in the first trimester, and RACGP talk about, may be offered to low-risk women, and that the decision to have screening is a personal choice made by the individual or couple. There is federal funding provided to a project called Mackenzie's Mission, which is looking at the outcomes and impacts of screening of a large number of couples, I think based in Victoria, and looking towards more of a population-based screening for those who want it in the future. So the background of Mackenzie's Mission is that a young baby called Mackenzie was born and discovered to have a condition called spinal muscular atrophy, and she passed away at the age of 7 months. And her parents, after discovering that this was a genetic condition, wanted to know why they hadn't been offered carrier screening pre-pregnancy to help them make decisions around approaching pregnancy. Here's a quick reminder from that article I was referencing. It's an easy reminder about the inheritance of recessive conditions, which you'll see on the right of the screen, on the left of the screen, and the X-linked conditions on the right. So that can be a really useful way of, again, explaining to patients as well. So these tests, looking at the most common genetic changes in the Caucasian population. So the three most common conditions, cystic fibrosis and spinal muscular atrophy, which are both inherited in that recessive pattern, and Fragile X. So those three conditions combined have an incidence similar to trisomy 21 and Down syndrome. So even though each of them are rare conditions on their own, the three of them put together have a significant incidence. These tests can be ordered through the normal pathology channels. You can just use the ordinary request forms and ask for preconception genetic carrier screening. The cost is what is the prohibitive factor for people at the moment. It's about $400 and there's no Medicare rebate that applies at the moment. The second part on the screen, Advertis Diagnostics, is a much more expanded panel testing for over 500 separate conditions, and some of these tests need to be done overseas. So checking that out in terms of turnaround times and expense is a particular consideration at the moment. This might be one of the topics that people would like some more info on in the future. I'm happy to expand further at another time if people would want to. So I'll now move on to some case examples and a chance to do a little bit of thinking. If you've got a pen or paper handy or you want to make some mental notes, if we were together in person, we'd open this up for discussion, but our web-based presentation doesn't quite allow us to do that, so have a quick think. Julie's a healthy 24-year-old whose last period was 4 weeks ago, whose urine pregnancy test is positive. This is her first pregnancy. She doesn't have private health cover and she wants to know what comes next. She's booked a 15-minute appointment. What do you do? If you're not sure what to do, that's where your CQ summary card comes into play. This is kind of your one-stop shop for all the things that you need to know when it comes to antenatal care. So you can see in that first visit, you're looking at confirming her pregnancy and looking at dates, reviewing her history, allergies, medications, looking at any risk factors that might be present for her pregnancy. Think about a scan if the dates are uncertain or there's other risks. Talking about folate and iodine supplementation, perhaps briefly talking about screening for genetic conditions or trisomy conditions versus diagnostic testing, thinking about the models of care and what she might choose for pregnancy care, getting a record of her pre-pregnancy or early pregnancy, blood pressure, weight, height and BMI, and then looking at the lifestyle stuff, diet, alcohol, smoking, and offering influenza vaccination if that's available at the time. So you can see that's a lot to cover, and it doesn't all have to be done in one visit. Sometimes having a bit of a plan as to what you do, organising some initial tests for her to do maybe around the 7-week mark and a dating scan then, and getting her back with those results to finish running through all those factors that you're going to talk about. Let's move on to some of those topics. So there is still a recommendation for women to have an iodine supplementation if they're pregnant, breastfeeding or planning a pregnancy. So iodine, 150 micrograms daily. Separate rules for those who've got thyroid conditions or have Graves' disease, and they need to be considered separately. Ideally, they should be taking an iodine and folate supplement at least a month prior to conception. So we do have iodine fortification of bread. That's been in the system for over 10 years now, but it's not at high enough levels for pregnancy, so women are still recommended to have a supplement. There's a multitude of pregnancy and breastfeeding formulations, tablets and capsules. Often they have a large number of ingredients, but really the two that are most worthwhile are the folic acid for preventing neural tube defects and the iodine for normal thyroid and brain development. If people are concerned about costs, then there are formulations like iFolic, which just has those two ingredients and is much cheaper at $15 to $20 for 150 tablets compared to something like Elevate, which might be $60 for 100 tablets. Adding iodised salt is also a good way of getting a little bit of extra iodine in people's diet. STI testing in pregnancy. So for our case example, Julie, who's under 30, recommend for her to have a chlamydia test, whether that's a self-collected vaginal sample or a first catch urine. Other people who really should get a test are those of Aboriginal Islander background, if they've had more than 2 partners in the past year or a recent change in partner, if they've had another STI in the past 12 months, or they've had a sexual partner in STI. Syphilis testing is really important as well. So there's universal testing. Everyone should have a syphilis test in that first lot of bloods. Women who are at increased risk of an STI, so those who are Indigenous or have had another STI, it should be carefully monitored and retested later in pregnancy and if any of their circumstances change. And then women who are at high risk are those who are Indigenous and living in an outbreak area, if they've had known contact with a syphilis case, if there's substance use, particularly ice, if their partner has male as well as female partners, then they require more testing through pregnancy. So testing at that first visit, repeating it at about 20 weeks, again between 26 and 28 weeks, and then again between 34 and 36 weeks and after birth. So it sounds like a lot of testing, but syphilis is an increasing problem. Central Queensland is a declared outbreak area, so we have higher rates of syphilis than many, many other places. There have been 7 outbreak-associated deaths in preceding years, and there have been deaths from neonatal syphilis, and that's entirely preventable. There's a really useful flow chart in the Queensland Clinical Guidelines, syphilis in pregnancy. So I encourage you, particularly if you've got some Aboriginal Islander patients that you're caring for, perhaps having a look at that so that you can match that testing to the guidelines. Next, we move on to early ultrasound. This is a slide from one of the private networks, not to suggest that we're recommending one over the other, but you'll find that your preferred provider will have one of these kind of lists as well. So it's a reminder about the services for which a Medicare rebate applies. So for scans under 12 weeks, there are certain conditions and information that you need to give on the request form to enable your client to have a Medicare rebate. And then later scans, so over 22 weeks, any medical practitioner can refer for one service per pregnancy when there are the conditions in this second list that you'll see. They can have multiple further scans rebated if they're referred by a specialist obstetrician gynaecologist or by a GP who's got a diploma in obstetrics. So you'll see those 2 lists of conditions there. So that the lists are, quite long. There are many conditions for which a Medicare rebate is applicable. So it does make sense to just check whether your patient fits those groups so that they can obtain a rebate that they're entitled to. First trimester combined screening or nuchal translucency screening. There are a number of indications, again, for where a Medicare rebate applies, and that's for maternal age more than 35, if there's a risk of miscarriage, if there's a risk of fetal abnormality, dating scan for uncertain dates, pregnancy after assisted reproduction. So this, again, is just to clarify what was on the previous slides. So I guess particularly that relates to later pregnancy and growth scans. So GPs who don't have a diploma of obstetrics can only refer for one scan in that later part of pregnancy. You might need to discuss that with the person's treating team if there's a request for repeated scans. Diabetes in pregnancy is one area that's had a little bit of change due to the pandemic. So I've got these slides now and some others that show us what we were doing previously. So you may already be aware of these, but the changes are that we would do an early HbA1c rather than early GTT for women who are at risk of diabetes or at pre-existing risk of pre-existing diabetes in early pregnancy. And for women who've had GDM, delaying their postpartum glucose tolerance test to about 6 to 12 months. And that's designed to reduce time that people are spending in a collection centre, allowing them to stay home more of the time. So again, you can find these changes easily at the top of the Health Pathways Antenatal Care page. But in summary, so rather than doing a GTT in the first trimester, do an HbA1c. And then in that mid-pregnancy test, rather than screening everyone with a GTT, we're now doing a fasting blood glucose. If that's normal, they don't need a GTT. If they've got borderline, then they still do need a GTT and then manage according to the results. And if their fasting glucose is high, then they're automatically assumed to be a gestational diabetic. So pre-COVID, these were the rules that we're applying. I guess I'm not sure how long our new rules will be in place for, so we'll see what changes with time. So again, pre-COVID, we were starting to use HbA1c as a diagnostic test for those women in the first trimester. Again, Queensland clinical guidelines have got a flowchart around screening and diagnosis of gestational diabetes. Should these women have shared care? Well, it depends on the circumstances. They may be able to have a modified system of shared care in consultation with the hospital team and the GP. Let's have a think about another case example. So Anna, who's 32, she's got a BMI of 40. A pregnancy test is positive. She's been on thyroxine for years. The medical history is unremarkable, although she does remember that she did have retinoblastoma. What are the factors that you want to take on board here? What things do you need to particularly think about? So in her history of retinoblastoma, it can be a genetic condition. So 40% can be inherited in an autosomal dominant pattern. So it can be associated with other types of cancers, and these families do need genetic counselling and close follow-up. It's not in here because we think GPs should be geneticists, but the point of this history is to encourage all the team to have a thorough history and to include those things in their referrals and communication with the other team members, so the hospital team. If you're in doubt about something, look it up or phone through. We're not even going to touch on the thyroid issue at this stage, except to say that thyroxine needs increase and should increase the dose by about 30% in early pregnancy. Here's another example, Nicole, who's 38 and an Islander woman. She's got a pregnancy test which is positive, but her cycle seems to have been a bit irregular. She's been taking some folic acid, but she wants to know what to do next. What factors do we need to consider for her? It's important to record the Indigenous status of mum and baby. Think about your local area and are there any specific Indigenous services available or hospital considerations? In Rocky, we have Gamagundu, which is the Indigenous midwifery service team. They've been now working in the area for 10 years. So women of Indigenous background may want to have care in that particular team aspect, or they may elect to have antenatal shared care under the usual kind of protocols as well. Nicole's also 38, so it puts her in that bracket of advanced maternal age. Should there be any change in her hospital booking or appointment procedures? I'd suggest that we talk to her more specifically around some screening and testing options in pregnancy. So congenital abnormalities do fall into 3 broad categories. those involving chromosomes, the structural abnormalities like spina bifida, and then genetic abnormalities, and we've touched on those before. You'll all be very familiar with the increased chance of chromosomal abnormalities with increasing age. When you're talking with people about screening and testing, it's important to assess their knowledge to know where they're starting from, because there can be limited community understanding of the chance of abnormalities and what that means for a pregnancy and a baby. Avoid making assumptions based on their previous pregnancies or their culture or religion. Provide verbal and written information. Provide support and care for people if they decline to have testing. Think about the language that you're using, talking about the chance of a particular genetic change is much more acceptable to people than talking about the risk of something. And having testing can raise a lot of anxiety in people, so be mindful there, and do document what information has been given, offers of testing, and what the outcomes have been there. The benefits and risks of early screening and testing are that there is the opportunity to terminate an affected pregnancy if that's the choice made, that there may be an opportunity for prenatal intervention, preparing for a baby with special needs, particularly identifying those at risk, perhaps birthing in a larger centre, maybe preparation for palliative care. Think about the risks of testing, so the risks involved with CVS or amnio compared to minimal risks involved in a morphology ultrasound, and that having tests may increase people's anxiety and or provide reassurance when the results are known, and that there of course are costs involved with testing. So the screening tests we have are the non-invasive prenatal testing, looking at cell-free DNA from the maternal circulation, combined first trimester screening, that's the nuchal screening, the second trimester triple test, and morphology scan. So they're all screening tests, and they look at the chance of any particular diagnosis being present. The diagnostic tests include CVS, the amnio, tertiary ultrasounds, and fetal MRI. And that really is looking at a yes or no answer for any particular condition. A little reminder about CVS and amnio, how those are done. CVS is an early test, from around 10 weeks. It's a sample of the placenta. Amnio can be done from around 14 weeks and takes fluid from around the fetus. So there is a risk of miscarriage from these procedures. Combined first trimester screening, it's not just a nuchal scan. It needs to be combined with the blood results of Pap A and beta HCG. Accurate dates are needed to make sense of the numbers. It's a very sensitive test, detects probably 9 out of 10 situations where trisomy 21 is present. About 1 in 20 women will have a high risk result, so that their chance of trisomy 21 in this pregnancy is 1 in 300. The other things to remember are that increased nuchal translucency is associated with other problems and conditions as well. So if that's the only thing that's present, then it's probably wise to have a tertiary scan at around 18 to 20 weeks. Look at their chromosomes. If they're normal, then perhaps looking for some smaller deletions or duplications. If the Pap A is low, then that again can be associated with later pregnancy problems, preeclampsia, growth restriction, and stillbirth. So in those cases, monitoring fetal growth and doing some Doppler assessments and growth scans can be really important. So if people choose to do the NIPT for a more specific diagnosis of a trisomy condition, it's probably still a really good idea for them to have a scan assessing nuchal translucency and still looking at Pap A, because both of those can be helpful as well. If the first trimester screen opportunity is missed, then triple test can be done in the second trimester. So it does have a higher false positive rate, but it does add a risk assessment for the open neural tube defects. Again, should be done in conjunction with a dating scan to get the best performance, but it can be done later and it's cheaper than that combined first trimester screening. So all women should be offered first trimester screening, and we GPs are the ones who are seeing women in early pregnancy. Women should be aware of their options, including the limitations of testing, the differences between screening and diagnostic tests, and thinking about what they would do with the results when they've had those tests done. A further case example, Kate. She's 34, it's 11 weeks since she had a period. She's not sure how she wants to proceed, and she does want to consider any possible pregnancy complications or abnormalities in the pregnancy. She knows that she's got a negative blood group. So particular points to note in her case? Well, she's already identified that her pregnancy is unplanned, and probably still around 50% of pregnancies are unplanned. It doesn't mean that they're unwanted. It may be mistimed, and people may be happy to continue a pregnancy. So I think never make assumptions. Don't leap in with congratulations if someone says that they're pregnant. Try and assess how they're feeling about things first. There is an IDA number 4001, which applies to non-directive pregnancy support counselling that lasts at least 20 minutes in relation to a current pregnancy or a pregnancy in the last 12 months. If she doesn't want to continue with a pregnancy, what are her options? Medication terminations available for those up to 9 weeks gestation. She may well be a further gestation than that. It's 11 weeks since a period. Surgical termination, again, may be appropriate for her. Children by Choice is a great resource for both health professionals, women, families, anyone who's looking at information around making a decision for an unplanned pregnancy. So you can see their website there. They've got a 1-800 number that you can call for a callback as well. Lots of resources on their website, including some kind of self-directed questionnaires to help people clarify how they're feeling. Our local pathways, of course, are on health pathways. So in Rocky, there's a private provider of surgical and medical termination at Murray Stopes. True does provide medication termination up to 9 weeks as well. And if GPs are interested in knowing more about becoming a provider of MTOP, then the PHN will be supporting a webinar in October to provide some more information upskilling in that area. The other point in the case we just mentioned is the Rh negative status. So women who are Rh negative are in two categories, those who have anti-D antibodies and those who do not have anti-D antibodies. If they've got antibodies present already, then they're not suitable for shared care. Women who are negative should get a dose of anti-D for a miscarriage at any gestation, anytime there might be the spill of fetal cells into maternal circulations. So threatened miscarriage, APH, abdominal trauma, if they're having a aversion later in pregnancy, or amnio or CVS early on. And again, postpartum if their baby has a positive blood group. Anti-D should be given within 72 hours of the sensitising event, a smaller dose in early pregnancy, a larger dose afterwards. Negative women also should have routine anti-D at 28 and somewhere between 34 and 36 weeks. That can be given in general practice. You can order it in and hold it in an immunisation fridge. Rocky Hospital really is planning to see women around that 28 and around the 34, 36 weeks mark to make it easy for giving them anti-D. But if you happen to be seeing them and they do need their injection, then I would suggest that you ring through to the team leader phone to check where and when they should present to get their dose of anti-D. So the Red Cross and QML will deliver doses of anti-D. It should be recorded in the patient's pregnancy health record. It's an IM injection. It may only be worth keeping it if you do see lots of pregnant patients. Here's our 3-slide touch on mental health in pregnancy. And again, this is something that we could probably spend half a day really talking about in detail. But again, a reminder that PND is very common, maybe as high as 20%, somewhere between 4 weeks and 12 months following the birth of a child. If it's severe, you might need to consider whether the person has bipolar disorder instead. Antenatal anxiety and depression is also very common, and there are routine screening for mental health is recommended, and that's included in the pregnancy health record too. Sadly, suicide is still the most frequent cause of maternal death in that postpartum period. Often violent means are used, and the highest risk period is between 6 weeks and 12 months after diagnosis. So a high proportion of people have a serious mental illness. It's also a high incidence of women who've had perinatal complications. The risk factors include a history of mental illness, significant medical or obstetric complications, difficult delivery, if they've been on medication and stopped it, if they've had sudden hormonal changes, for example, weaning their baby suddenly. Those women using substances or abusing substances or over-the-counter medication are also at risk. Those who are anxious as well, and women who've used corticosteroids, maybe a high dose or a long course. Family history, again, is very relevant. That increased risk with a first-degree relative, and increased risk, again, in those relatives who've had a perinatal onset of mental health problems. So just like we're normalising screening for mental health, it's important that we're screening for their safety at home as well. So intimate partner or family violence, domestic violence affects many women. I'd recommend that you see women alone for at least part of their consult so that you can ask these questions with confidentiality assured. Also recommend that you ask them more than once during pregnancy. It may take some time before women are able to disclose a history of feeling unsafe or a history of violence, and it's important for them to know that you're able to support them and able to offer help. So perhaps normalising it, just adding a question like, in addition to the blood test and ultrasound scans we recommend in pregnancy, we ask every woman questions about how she's feeling and if she's safe. Anxiety, depression and domestic violence are common conditions, and they may occur for the first time or get worse in pregnancy. Are you safe? RACGP White Book, again, has got some great resources around specific populations and in pregnancy in particular. Moving now to vaccination. So vaccination not just for mums, but also pertussis immunisation for those in contact with new babies or around new babies. So every 10 years for fathers or partners, extended family members, household contacts and medical staff. The standard plan for vaccination before, during and after pregnancy. So preconception, MMR, if you've checked someone's rubella status and they're not immune, you should update that. Influenza can be given preconception, and chickenpox vaccination for those who are not immune. Pneumococcus for at-risk women. During pregnancy, influenza, again, safe at any gestation, and then the DTPA from 20 weeks onwards. The only one that's absolutely contraindicated is smallpox vaccine, although live vaccines are not recommended generally. Then postpartum, again, pertussis if that hasn't been given in the antenatal period, and MMR if that's not been given earlier as well. This little graphic shows that vaccination works. So it's an older table, but it shows the number of deaths that have occurred from the diseases that we protect against with vaccination now. And the highlighted sections show the decade in which community vaccination started for that disease. And you can really see how effective vaccination is as a public health measure. This next section is thanks to Gary Rajapati. So she's put together some slides around integrating antenatal shared care into your GP work. Have a think about what MBS item numbers you're using. Do you know which ones relate to antenatal and postnatal shared care? Have you been billing any so far? Here's a list of the item numbers that you could be using. And here's the last year's fees, 85% benefit, and the extended Medicare safety net cap. Thinking about an antenatal consultation. So Jessica, who's a prime-ep at 30 weeks, and she's come for her routine antenatal appointment. What do you need to cover? How her pregnancy's going, any issues diagnosed, is she feeling fetal movements, has she had any other symptoms or concerns, checking again whether she's a smoker and advising her around cutting down and ceasing. Has she had her whooping cough vaccination? Has she had an anti-D? Blood tests done at 28 weeks? Is she taking any medications? Doing your general examination, checking her blood pressure, checking her urine if needed, the obstetric examination, fundal height, fetal heart. Talking about her iron supplements, checking her next antenatal clinic appointment, when she's next going to the hospital, and then planning a follow-up appointment for her with you as well. So these are all the things that you'd normally do at that time in pregnancy. And for that, you can bill an antenatal attendance. Another item, 16591. So this is for planning and management of a pregnancy. The pregnancy is over 28 weeks. You're not the person who's planning to deliver this pregnancy. It also must include a mental health assessment, including screening for drug and alcohol use and domestic violence. And it's not payable if you're the person providing intrapartum care. So the mental state examination needs to be documented using the Edinburgh scale, again, specifically screening for domestic violence, but it can only be billed once per pregnancy. If I get back for a second, you'll see that the 75% benefit is, so the 85% benefit is $125. So it is one of the higher item numbers in the antenatal care numbers, but can be billed just once per pregnancy. The COPE guidelines are really useful for mental health care in the perinatal period, and that can give you some tools for doing those assessments pre and postnatal. The next item number is for a professional attendance as part of a single course of treatment if the patient's been referred to you by a participating midwife. So you may need to work out whether you're eligible, whether you're working with any midwives, perhaps those midwives working in private practice, who might refer patients in for treatment required. So it's payable once per pregnancy. In the postnatal time, for example, Kate, who's 28, comes for a postnatal check with her 6-week-old Abby. What do we need to check in her history? What examination do we need to do? Does she need a mental health assessment? What's the management plan, and what item numbers might apply? So for her, 16407 could apply. So that's a postnatal attendance by a GP or obstetrician 4 to 8 weeks after the birth and lasting at least 20 minutes. It must include a mental health assessment, including drug and alcohol screening and domestic violence screening, and it's payable once only. The other option is 16408 if it's between 1 and 4 weeks after the birth, and for a patient who has had their birth as a private admission. The other number we mentioned earlier was 4001, and this is the non-directive pregnancy support counselling. So for a person who's currently pregnant or has been pregnant in the 12 months preceding this. To claim this item number, you do need to complete the pregnancy advice and support module, and that's available through RACGP. About 4 hours online learning. So our next section brings us to communications and referrals. And early referrals are really key. The hospital's intention is to review women perhaps between 14 and 16 weeks, or at least by 18 weeks. There is a template that covers all the required referral information, and that can be completed and sent through to the referral centre in Rocky, or if you're outside of Rocky, using that shared care card will tell you where those referrals should go. The pregnancy health record or the patient held record can be given to women in early pregnancy. So if you're doing lots of antenatal care, you can get a supply of a few books from the hospital and provide them to your patients. If you've got urgent requests, then certainly phone the on-call registrar at the hospital. So the important points in that referral are to include that results of the first trimester screening, full blood count, including ferritin for our local area. Reminder that women with that higher BMI should have that first trimester HbA1c and their electrolytes and liver functions, and some urinary protein creatinine ratio. At 26 to 28 weeks, again, repeat bloods, and again, a blood count at 36 weeks. So all these again included on that summary card and included in the patient's pregnancy record. The template or booking in form is in this format in the paper chart, so that comes in the PHR, but there's an electronic version that's available for best practice and medical director. So you can find that on Health Pathways. You can go to Forms and Templates, and that will bring up, this is the first page. When you scroll down, that will bring you through to the CQHHS Specialist Outpatients Department, and you can see at the bottom of the CQHHS section is the maternity booking and referral, and you can download the template for best practice or medical director or a PDF template. So that practices should already have these downloaded. We did some work a couple of years ago trying to get everyone's systems updated with these referrals. If you're looking and you can't find it, please contact me, and one of the practice support people from the local PHN should be able to help you out with getting it downloaded. Here's another example for Health Pathways showing that it's got everything that you need to know around antenatal care and around shared care. So if you haven't used Health Pathways before, all those little blue sections are links or drop-down menus that give you more information. When women come to see you for their routine antenatal visit, your medical software will probably have an obstetric visit template that gives you an easy way of recording the information that you need. So that visit can be printed out or it can be written in the woman's patient held record. One day we'll hope that there'll be an electronic version that communicates between the hospital and primary care. For the moment, that's not the case, so we do need to use the pregnancy health record as the main means of communication. So again, if you haven't seen them before, this is what it looks like, a little blue folder with that yellowish card inside. If you want to know what it contains, you can go to the Clinical Excellence Division of Queensland Health, and you can actually download all that information that's in the PHR. So it is actually the woman's medical record, so it will be kept in the hospital chart after birth. It really is that communication tool for anyone caring for that woman during pregnancy. Any tests that are undertaken during pregnancy should have a copy sent to the hospital. That first trimester screening, those early blood tests, I'd suggest that you have all those results together and then send them with the referral in one go. Asking for a copy to go to antenatal clinic, I think, is still important. And in my role, I'm continuing to talk to the hospital about the efficiency of the results transferred, because we know that the results don't always marry up with the patient's file, and it means a lot of extra work in many areas trying to get an efficient system going for results meeting up with patients' records. In the meantime, please provide patients with a copy of any results that they can keep in their blue PHR folder. I know we're trying to reduce the paper that we use, but for the moment, this seems to be the only way of making sure that all the results are in one place, and that's with the patient. Who's responsible for abnormal results? Well, the clinician who orders the test. So even if you sent a copy through to the hospital, if you've got a result that you're worried about or where something needs to happen, if you've ordered the test, then you need to be taking action on that. There are some specific guidelines in the Mater Mothers booklet, but if you're concerned, ring through to the registrar, ring through to the team leader midwife, and they'll be able to help you as well. What can we expect to hear back from the hospital? Well, we should get a letter back that says that their referral's been received and that they've been allocated to an antenatal clinic. When they visit the hospital, everything that they do will be documented in the PHR. And after people have had their babies, the aim is for a discharge summary to come back to their identified GP within 48 hours. And again, there is some behind the scenes work going on with the hospital about improving the rate of discharge summaries coming out in that time frame. Very happy to take feedback, probably in the form of email would be great. So any concerns around obstetric discharge summaries, please let me know so that I can communicate those through to the hospital. This is kind of the nitty-gritty of the appointment schedule. Again, it's outlined on the shared care card. But early on, really people should be seeing someone before 12 weeks of pregnancy. And I think that's certainly the case. We're seeing lots of women very early. Those first visits, do you call them antenatal care or do you call them diagnosis of pregnancy? Do you spread out those tests and information over a number of visits? They'll have their hospital bookings somewhere around 14, 16, 18 weeks with the midwife and or the medical team. Then primates may have a total of up to 10 or so visits over their pregnancy. About every 4 weeks in the first trimester, 2 to 3 weekly in the second to third trimester, and then generally weekly from 36 weeks. So the hospital are now probably planning to see people for booking, and then again around 20, 34, 40, or depending on who you're talking to, it might also be around 28, 34, 36, and another visit planned if they're post dates to organise induction of labour or delivery. So this kind of information again is outlined in the PHR. So it's all written there. There's lots of check boxes, lots of things to talk about. And if the patient has their PHR with them, then it's very easy to find and discuss. These are the later pregnancy visits. Also recommended to talk to women about their plans for feeding their baby. Talking about breastfeeding during pregnancy is important. Talking about the support that's available, whether that's through the Australian Breastfeeding Association, hospital or community lactation consultants, child health nurses, or perhaps giving them some written information or direction to websites. Talk about vitamin K, Hep B, their birthing preferences, at what point should they go to the hospital, and talking about what's expected postnatally as well. So all important for holistic care. So if you're concerned about someone, phone a friend. Who can you ring? Well, depending on where you are, there's numbers on this card for Rockhampton, Emerald, Gladstone and Billow. So in Rocky, generally it would be the ONG registrar or the triage midwife speaking to those people. For postnatal care, there's a wealth of online resources for clinicians, for patients and their families. This is just a list of some of those organisations. They're not direct links there, but they're all easy to find. final few words from the midwives at Rockhampton Hospital. What they want GPs to know? Well, they really appreciate early referrals. So they would like GPs to review that first trimester screening, the nuchal scan, and then send results through together with that. They do plan that booking visit around 16, maybe stretching out to 18 weeks now, but it can be earlier or urgent if that's needed. So if there's someone who you know has a medical problem or that there are concerns in that early pregnancy, then contact the midwife team leader, antenatal clinic, and that can be organised sooner. So the midwives assure me that people can be seen within the week if necessary. The hospital will contact women for appointments once those referrals have been received. So you or the patient don't need to ring back and check what's happening. As long as you're confident that the referral's gone to the right place, then the hospital will contact those women. It's not shared care, but if people have a preference for the midwifery group practice, again, early referral is important because those places do fill quickly. A couple of changes that are current now with the COVID-19 pandemic. So things that have changed, women may be invited to have their booking visit by phone and then a shorter face-to-face visit following that. So that first booking visit that they do with the midwives can be up to 2 hours in length. So it's very detailed, and you'll see if you look at that PHR that there's a lot of information to be covered. So doing lots of that by phone and then planning a shorter face-to-face appointment reduces the time that people are spending in hospitals. Women are being encouraged to attend their clinics alone, so perhaps not bringing children with them unless they absolutely have to, not bringing partners with them unless they absolutely have to. So it is a bit of a change and changing those support systems, but again, helping to reduce the numbers of people who are out and about. For GPs, we've got the option now for telehealth as well, and there are some guidelines around when those appointments can be made for telehealth rather than face-to-face in later pregnancy. For women who are birthing at Rockhampton Hospital, they are allowed to have support people. They need to nominate who those support people are. They can have up to 2, and normally at around the 34 or 36-week visit at the hospital, they will need to nominate those people, and they can come and be present and stay while that woman is in labour and birthing. Then visitors to the ward, again, some changes there. Again, the same 2 nominated people, one of them who can be a child under 15, are able to visit just for a 2-hour block daily. They can choose that block somewhere between 8 AM and 8 PM, but they can only come up in that one time of the day. Rocky Hospital has also offered antenatal classes for a long time, and they've now made those available online so people can watch those anytime. And they're going to be running face-to-face classes second monthly. So the plan for that is September, November and January in the near future. There will probably need to be bookings and limits around the number of people able to attend those classes. So that kind of summarises, a whole day's workshop down to about an hour. I'm hoping that Jodie might be able to have collated some questions through if there's anything that people would like to know. In terms of feedback, Jodie will send through an evaluation that launches out straight after the webinar, so please stay on and complete that if you can, or that there'll be a link sent through to you 24 hours later with a recording of this webinar as well. So if you feel this has worked well and you think it's a worthwhile format for further education, please let me know in the chat or the evaluations or contact me directly. If you'd like to be listed as a shared care GP with the antenatal clinic, I guess I'm thinking particularly of people who may have been providing this elsewhere and are now new to Rocky. Again, let me know. I'm hoping my email's included somewhere in the information that you've been sent previously. Let me know and I can pass that through to maternity at the hospital. The other sessions that are coming up, as I mentioned, the 13th of October is our webinar about MTOP for GPs. If we can, in October, we'll have a face-to-face workshop based at the hospital, again, around antenatal care. We previously explored the idea of some clinical attachments through clinics at the hospital. They are on hold for now, but I do want people to know that that's still in mind, and we're hoping that in the future we'll be able to start that to give people a bit more hands-on experience in antenatal clinic. Let me know, I guess, if people are interested in some small group sessions or some other women's health topics. And overall, thank you for caring for all the mums and babies in our region. I might flick out of this screen and hand over to Jodie and see if there are any questions that we can answer.
Yeah, Helen, that was terrific and a lot of information in a very short period of time. So I'm sure people probably do have questions, but you're all being incredibly shy. So if you can send some questions through now, please do, because we don't have it. Here we go. We've got our first one now. I feel like I've missed this, but can women opt for hospital-only care even if they don't have a medical condition?
Yes, they can. Yep. So some people might choose to have hospital care if they feel confident and comfortable with that for whatever reason. Then that's entirely an option for them. What we've been trying to do, and the aim of my role as GPLO, is to increase the uptake of GP shared care as an option for people. So some of the disadvantages of complete hospital care in the past and in different areas have been that hospital clinics can be really busy. There can be a long wait for people at their clinic. They might feel like they're seeing someone different every time, and they don't know who's going to be around looking after them. So if people feel that those things are a disadvantage, then they might like to look at shared care with their known GP. But if people have a preference for being at the hospital for whatever reason, then when you write your referral through, you can put all that information, all the results, everything that you've done in those early pregnancy visits, and put a note in that says, this patient would prefer to have hospital care.
Thanks, Helen. I hope that's answered your question, Dana. Has anyone got any other questions? Dana's just saying thank you. I've got another question here from Barbara. Patients in Gladstone disappear to the MGP and we see them at 1 week postpartum. Why can't we share care with MGP?
Yep. I think this has been a question that's been raised before around having still some medical and GP input during pregnancy for those women who are having MGP care otherwise. So that's something that I am keeping in discussion with the hospital when we're talking about those models of care. I think MGP is really popular in Gladstone, and I think I've heard that women, do their home pregnancy test and then ring MGP themselves so that they can get onto the program as soon as they can. But I know that there's some difficulties with GPs that you then miss out on all the things that happen during their pregnancy, and suddenly you see them with a baby and you're trying to catch up on 10 months worth of events when even a few visits during a couple of visits during pregnancy could have made a big difference for continuity of care.
Thanks, Helen. I've got another question that's come in. I had one patient today, 5-week pregnancy, wants to know non-invasive pregnancy test. His last baby had chromosome 22q doubling. Should I refer her to genetic specialist or will it be AMC?
I would have to look up the details around that NIPT testing and what it covers, but I think you can do that expanded testing looking for the same condition again if you know that there's been a previous condition. That's someone who would warrant and potentially an early referral or potentially a phone call through to the ONG reg. If Jodie wants to pass that the person who's asked the question through to me, I can do a quick link to some information and send that back to you around NIPT and around options for people there, because genetic appointments generally have got a considerable wait, but in these conditions there might be a way of getting them a timely appointment.
Okay, Thanks, Helen. I'll do that. It might be in the next couple of days that you'll get a response from us. So
Yeah.
Thank you for that. Anybody else got any more questions? That's it that I can see for the moment. So I'll just give you a couple of seconds in case anyone does. And while we're waiting, I would just like to thank Helen for all her preparation for tonight's webinar. It's been fantastic, and whilst it's an introduction, it's been very comprehensive. So I really appreciate your preparation and hard work for that. And I'm sure everyone else does as well. I'd like to also remind everyone that after this webinar finishes tonight, you will have an opportunity to fill out an evaluation. The webinar is also recorded, and you will receive in the next 24 to 48 hours a copy of that recording and another opportunity to fill out the evaluation if you don't do so tonight. And also we have attached a couple of handouts, so don't forget that those handouts are available to you. We can also link to those with the follow-up emails that we send to you as well. Got another question that's come in as well. Can OGTT be requested after 28 weeks as one patient missed being overseas?
Yes, yeah, if there's a reason that they've missed it. At the moment, if you think they are at average risk of GDM, then the fasting blood glucose would be what's recommended at the moment. But if they would prefer to have a GTT, or there's some other reason that's relevant, then yes, you can do that at a later stage. And there are some poor women who end up with repeated GTTs through pregnancy. I guess if they've got a baby whose growth seems to be tracking on the larger side, there's no time limit for when a GTT can be done. It's done at that 26-week mark to try and get the most benefit of managing GDM early on.
Okay, thank you, Helen. Any more questions? Otherwise, I think we might call it a night and let you all get back to your families and have some dinner. Looks like we've done. Oh, here we go. Thanks. Oh, thank you, Barbara. Just a couple of people expressing their thanks. And thank you, everyone, for coming along and giving up your time as well tonight. That's fantastic. Really appreciate all the thanks that are coming in now. There's quite a few. So
thank you.
Yeah. So we might finish up now. Thanks, everyone. As I said, a recording will be available shortly. Don't forget, if possible, to fill out your evaluation form, because it helps us make these sessions better and better. So good night.
Good. Thanks, everyone. See you.
Well,